Welcome to the Hospital Medicine Unplugged podcast. Today, we're doing a really critical deep dive into a true medical emergency, the acute management and diagnosis of hyperviscosity syndrome, or HVS. For those of you practicing hospital medicine, this is definitely one of those conditions where time is tissue. Prompt recognition, prompt intervention, it can make all the difference. We're talking the difference between full recovery and, well, irreversible organ damage.
That's absolutely right. That assessment, you really can't overstate it. HVS is, at its core, an acute issue and potentially life-threatening. It results from this pathological increase in blood viscosity. The blood literally gets too thick.
Okay. And what's driving that thickness?
It's typically one of two things. Either you have elevated plasma proteins, think abnormal immunoglobulins usually, or you have just way too many cellular elements. Too many red cells or sometimes too many white blood cells.
But the end result is the same.
The common pathway, regardless of the cause, is severe trouble in the microcirculation, impaired flow. And that quickly translates into tissues not getting enough oxygen, tissue hypoxia, and then end organ dysfunction pretty much anywhere in the body.
So we have to be vigilant. This sounds like an emergency where your clinical suspicion really has to come first, maybe even bypass waiting for lab results.
Absolutely. It demands immediate action right there at the bedside and getting consultants involved quickly.
Right. The moment HVS even pops into your differential, every single minute counts.
It does. And for us, the classic clinical triad, the thing that should immediately make you investigate further consists of three main symptoms.
Okay, what are they?
Mucosal bleeding, significant visual disturbances, and acute neurological deficits. You see those findings, maybe combined with some vague things like really bad fatigue or a severe headache. That should be your hard trigger. Start the workup, get the consults.
Okay, I want to focus right away on something our sources really stress, this crucial guiding principle for physicians. Symptom severity does not reliably correlate with the lab viscosity measurements. That feels a bit counterintuitive. Why is there such a disconnect? And why does it mean we really can't afford to wait for that serum viscosity number?
Like a really critical point, and honestly, it's partly tied to the logistics of care. First off, getting that lab measurement of viscosity, usually reported in centipoise well, that can take hours. Sometimes you even have to send the sample out.
Right. Not helpful in an emergency.
Exactly. If your patient is symptomatic, particularly if they have CNS involvement, confusion, ataxia, maybe severe vertigo, any change in consciousness, or if they're having significant active bleeding, waiting for a lab value that just confirms what your physical exam is already screaming at you, that's just unacceptable.
So the clinical picture drives the ship.
Absolutely. The clinical presentation is the primary guide for management. HVS is fundamentally a diagnosis you make at the bedside. And if the patient is symptomatic, the life-saving intervention, which is often apheresis, it has to proceed immediately. We intervene to prevent rapid organ dysfunction, maybe even death, not just to make a number on a lab report look better.
And I suppose the viscosity measured in the lab, it's just one piece of the puzzle, isn't it? The microcirculation itself has its own dynamics.
That's a great point. The microcirculation is subject to all sorts of local factors, things like shear stress, the diameter of the tiny vessels, specific protein interactions. A bulk measurement of serum viscosity in a test tube just can't capture all that complexity perfectly.
It's like measuring how thick oil is in a can versus how it actually flows through a running engine.
Precisely. And there's also the element of chronicity. A patient whose viscosity has crept up gradually over time might tolerate a higher number, than someone whose viscosity spiked really acutely. We absolutely have to treat the whole patient, look at the whole picture, not just fixate on one isolated lab value.
Okay, let's unpack the why behind this. The etiologies. You mentioned proteins in cells. It sounds like the vast majority of the protein-driven HVS comes from hematologic malignancies, specifically plasma cell dyscrasias.
Yes, when we're talking protein-driven HVS, there are really two main players we need to think about. The leading cause, by far, maybe 80 to 90% of HVS cases linked to paraproteins, is Waldenstrom macroglobulinemia.
Okay, Waldenstrom. Why is that the big one?
It's because of the extremely high concentration of monoclonal IgM protein that these patients produce. IgM is the key troublemaker here. Now, multiple myeloma, that's actually a much more common malignancy overall, but it's a less frequent cause of symptomatic HVS. Still important though, especially if you have really high concentrations of IgG or IgA.
And this really boils down to the physics of these proteins, right? IgM is notorious for causing this outsized increase in viscosity.
Exactly. That's the rhizological heart of the problem. IgM is a huge molecule. It's a pentamer, 5 subunits linked together.
Wow, yeah, big molecule.
Very big.
And that high molecular weight, plus its tendency sometimes for abnormal polymerization and just its large irregular shape, all that dramatically increases plasma viscosity. You can think of the IgM protein acting almost like glue or just a physical barrier within the plasma. It causes this exponential resistance to flow, especially when the blood tries to squeeze through narrow capillaries.
And are there typical viscosity levels where symptoms start to pop up in these protein cases?
Generally, yes. Symptomatic HVS typically starts to emerge when the serum viscosity gets up around 4 to 5 centipoise. Normal is usually down around 1.4 to 1.8 centipoise, so we're talking roughly double normal or more.
Okay.
But, and this goes back to our earlier point, it's not absolute. We've seen patients with profound symptoms down to 3 centipoise. Maybe they have underlying heart issues or neurological problems making them more vulnerable. And conversely, you might see someone walking around relatively okay with a viscosity of 8.
Right, clinical picture first. Now, contrast that protein-driven scenario with the second major category you mentioned, the myeloproliferative disorders. Here, the problem isn't the protein, it's the cells themselves, leading to what you called whole blood hyperviscosity.
Correct. This is a fundamentally different pathophysiology. The mechanism of damage is quite different. So in conditions like polycythemia vera, it's the increased red blood cell mass, the high hematocrit, that jacks up the whole blood viscosity.
Because red cells take up more space?
Exactly. They occupy much more volume, and they're less deformable than plasma. So the resistance to flow becomes highly dependent on the hematocrit, especially at the low flow speeds, the low shear rates you find way out in the microvasculature.
Okay. And what about acute leukemia, specifically when we see those really high white counts, the marked leukocytosis? What's the big concern there?
Yes. Acute leukemias, particularly acute myeloid leukemia, AML, can lead to something called leukostasis. And here the problem is kind of twofold. First, it's the sheer number of cells, the hyperleukocytosis. But second, it's the nature of those cells, the immature blast cells. They're physically larger and much more rigid, less flexible than mature white cells.
So they literally get stuck.
They physically plug up the microcirculation. It's particularly dangerous in the lungs and the brain's vasculature. And leukostasis doesn't just block flow, it also causes localized tissue damage because of the metabolic stress and the high oxygen consumption by all those packed-in white cells. This increases the risk of acute respiratory failure or potentially life-threatening tiny strokes, microinfarcts in the CNS.
And that distinction is obviously vital because the main acute treatment, apheresis, is completely different depending on whether you need to remove plasma or cells.
Absolutely critical difference. You're thinning the blood, yes, but in 2 entirely different ways depending on what's making it thick. Plasma exchange versus leukapheresis.
Okay, beyond these more common hematologic causes, we also need to think about some special etiologies. You mentioned cryoglobulinemia earlier, adding that temperature dependence.
Right, cryoglobulinemia. It's fascinating and often really tricky. These are abnormal immunoglobulins or sometimes immune complexes that literally precipitate, they fall out of solution when the temperature drops below normal body temp.
So getting cold can trigger symptoms.
Exactly. This sudden precipitation can rapidly, sometimes dramatically, increase the plasma viscosity, causing cold-induced symptoms. We also need to keep in mind secondary erythrocytosis. You often see this in patients with severe chronic hypoxia, maybe someone with cyanotic congenital heart disease or long-standing very severe lung disease.
And the management there is quite different, has some unique pitfalls. We'll definitely circle back to that because the usual strategies for paraproteinemias like aggressive fluids or apheresis could actually be harmful.
That nuance is absolutely essential. And just quickly, I should also mention the really rare causes, things like connective tissue diseases, rheumatoid arthritis, maybe Felty's syndrome, where you can get such severe polyclonal hypergammaglobulinemia that even though it's not monoclonal, just the sheer quantity of immunoglobulin can sometimes cause HVS through mass effect.
Okay, so let's move to how these patients present clinically. The symptoms really reflect that blocked microcirculatory flow, right? Especially in those highly vascular, sensitive areas, brain, eyes, mucosal surfaces.
Exactly.
Yeah.
The symptoms often get grouped into 3 main buckets, ocular, neurological, and bleeding. Now, the most dramatic and often the earliest warning sign involves the eyes. While mucosal bleed, epistaxis, nosebleeds, bleeding gums, maybe spontaneous GI bleeds, that's part of the classic triad. The ophthalmologic findings are truly almost pathognomonic, especially in the paraproteinemias. They're defining. Why? Because the retinal vessels are essentially a window, a direct view into the microcirculation of the brain.
Wow, so fundoscopy isn't just optional, it's a mandatory acute diagnostic step if you suspect HVS. What exactly are we looking for in the back of the eye?
You are looking for the classic sausage link sign. That describes these grossly dilated and really tortuous retinal veins. They look like strings of link sausages because you see segments of extreme dilation alternating with constrictions.
Okay, sausage links. What else?
They'll also likely see peripheral retinal hemorrhages, little flame hemorrhages scattered around. And in really severe cases, maybe exudates or even signs that the intracranial pressure is high, like papilledema.
Papilledema, wow.
And here's the critical takeaway. These specific retinal changes might actually show up before the patient develops other systemic or neurological symptoms. That makes the fundoscopic exam an indispensable, real-time diagnostic tool. It lets you bypass those lab delays completely.
So if that fundoscopic exam is positive, you basically have your clinical evidence. You need to treat now, regardless of what the labs say later.
Precisely. You have objective evidence of end organ effect right there. Okay, focusing now on the neurological and systemic side. That microcirculatory failure in the brain, it can cause a really alarming range of symptoms.
Yeah, that sounds scary.
It is. And the neurological deficits are often what push for the most urgent intervention. We see symptoms ranging from things that might seem subtle at first, maybe just a headache, some dizziness, mild ataxia, all the way to catastrophic problems like acute confusion, stupor, seizures, and ultimately coma. It's all a direct result of that blood sludging up and impairing cerebral perfusion.
And systemically, beyond the brain, what else should we be monitoring for?
Systemically, you might see cardiovascular issues crop up. Chronic hyperviscosity, especially in those myeloproliferative disorders where the total blood volume is also often up, can lead to a high output state that can precipitate congestive heart failure, sometimes even pulmonary hypertension.
Because the heart's working harder to pump thick blood.
Exactly. It's trying to push sludge through the pipes. And then the skin. Sometimes the skin gives clues, particularly with those more complex etiologies like cryoglobulin. In severe plasma hyperviscosity, especially if it's related to protein deposition, you might see things like levator reticularis, that lacy, purplish pattern on the skin, or purpura, sometimes even digital ischemia or skin ulcers.
Okay. And that brings us back to cryoglobulinemia, which you said presents very differently depending on the type. That seems crucial for diagnosis and treatment.
Understanding the types is absolutely paramount because the treatment path really diverges. We generally categorize them into three types. Type 1, cryoglobulinemia, is monoclonal. It's almost always associated with the lymphoproliferative disorder. Again, Waldenstrom or multiple myeloma are common culprits.
And type 1 behaves like the classic HVS.
Pretty much, yes. Type 1 is typically associated with those classic severe HVS symptoms we've been discussing. The mucosal bleeding, severe neurosensory signs like blurred vision, diplopia, confusion. It also commonly presents with acral hypoperfusion or even a necrosis, think painful Raynaud's phenomenon, maybe digital ulcers. Type 1 is the one that acts most like straightforward paraprotein-driven HVS.
Okay. And how do the mixed types differ? Type 2 and type 3.
Right, mixed cryoglobulinemia, that's type 2 and type 3. This is where the clinical picture really shifts. It leans much more towards vasculitis and inflammation, rather than just pure hyperviscosity sludge. Type 2 involves a monoclonal component, but it's strongly associated with chronic inflammatory conditions, classically hepatitis C virus, HCV infection. Type 3 is polyclonal, and you see it more with other autoimmune diseases.
So while type 1 is primarily a rheological emergency, a flow problem, types 2 and 3 are more like inflammatory or vasculitic emergencies, although viscosity can still be a factor.
Precisely. Mixed cryoglobulinemia usually presents with more systemic vasculitic features. Things like palpable purpura, especially on the lower legs, that levator reticularis pattern, again, maybe a sensory motor polyneuropathy, and often significant kidney involvement, proteinuria, hypertension.
And recognizing that vasculitic pattern points you in a different diagnostic direction.
Immediately. It guides your differential diagnosis straight towards looking for underlying infections, especially HCV, sometimes HBV for mixed cryo, rather than the primary hematologic malignancy you suspect with type 1. You absolutely have to identify and treat that underlying trigger, often the infection, because that is the disease-directed therapy for mixed cryoglobulinemia.
Got it. Okay, let's transition into the comprehensive diagnostic evaluation. You've really hammered home that clinical symptoms dictate the urgency, and we absolutely cannot delay therapy waiting for viscosity results. But assuming therapy is initiated or about to be, what role do the various lab tests play then?
Okay, so the lab tests are essential, obviously, for confirming the diagnosis eventually, for figuring out the exact etiology, which is critical for long-term therapy, and of course for monitoring how well the treatment is working. The first line measurement, when you suspect HVS, is usually serum viscosity, We already mentioned that symptoms typically kick in when it gets above 4 to 5 centipoise, so that gives you a critical baseline number.
But what if the patient is clearly symptomatic, maybe confused, bleeding, but the serum viscosity comes back at, say, 3.5 centipoise, below that typical threshold?
Yeah, that's a great question. It tells you one of two things. Either that particular patient is just acutely sensitive to even minor changes in viscosity, OR, and this is crucial. It suggests the underlying problem might not be primarily plasma protein driven.
Ah, okay. Which leads us to the other measurement you mentioned.
Exactly. It leads us to consider whole blood viscosity, or WBV.
And when is WBV more informative than the standard serum viscosity?
WBV provides really critical diagnostic value when you suspect the cellular elements are highly elevated. So think polycythemia or those acute leukemias we discussed. Because WBV is profoundly influenced by the hematocrit and the white cell count, it gives you a much more complete picture of the actual resistance to blood flow when the cells are the main source of the thickening. So if a patient presents with clear CNS symptoms suggesting microvascular blockage, but their standard serum viscosity is low or maybe just borderline, you absolutely have to investigate the cellular component, ideally with WBV.
Is WBV readily available everywhere?
Unfortunately, no. WBV is less universally available in hospital labs compared to serum viscosity, which can be a limitation.
Okay. Let's outline the specific lab workup then. If we're leaning towards a plasma cell dyscrasia, what's the sequence? How do we nail down which protein is causing the trouble?
Right, for plasma cell dyscrasias, you need to confirm there is monoclonal protein and quantify it. That requires serum protein electrophoresis, the SPEP. Then you need immunofixation electrophoresis, the IFE, which specifically identifies the class of immunoglobulin involved. Is it IgM, IgA?
SPEP, then IFE. Got it.
And you also need quantitative immunoglobulins measuring the actual levels of IgM, IgG, and IgA. This whole battery of tests helps you confidently tell the difference between, say, Waldenstrom and multiple myeloma. And here's a specific, really high-yield nugget for everyone listening, especially in hospital medicine. If you see IgM levels exceeding 60 grams per liters, that is strongly predictive of symptomatic HVS and Waldenstrom macroglobulinemia. That number, 60 GL, is a critical alert threshold.
Wow, okay, so that concentration gives you not just diagnostic confirmation, but maybe even a prognostic clue or a reason for preemptive action, guides you towards getting hematology involved early, even if the patient is only mildly symptomatic right now.
Precisely. It's a very useful threshold. Now, for the cellular causes, obviously a complete blood count, the CBC with a differential is absolutely non-negotiable. Hyperleukocytosis causing leukostasis. Often you're seeing white counts way up above 100,000, although remember, symptoms can sometimes arise at lower counts in AML because of those sticky blast cells.
And you mentioned the peripheral blood smear earlier. What are we looking for there?
Yes, the peripheral blood smear is crucial. You are looking specifically for rouleaux formation.
Can you explain rouleau formation again and why it's so significant here?
Sure. Rouleau formation literally means stacks of coins. It's where the red blood cells, instead of floating freely, aggregate and stick together in these long chains or stacks. Seeing this is highly suggestive of hypergammaglobulin-anemic HVS, especially with IgM. Basically, the excess protein coats the red cells, neutralizing their normal negative surface charge that keeps them apart and allows them to stack up like coins. So seeing striking rouleau on the smear is a rapid visual clue that your patient's viscosity problem is likely protein-driven, even before you get the quantitative immunoglobulin levels back.
That's a great bedside, or at least scope side clue. Now, I want to circle back to the cryoglobulinemia workup for a second. You mentioned a really specific technical requirement that sounds easy to miss but is absolutely critical.
Yes, this is so important and easy to mess up in a busy hospital. For cryoglobulin quantification and the cryocrit measurement, the blood sample must be collected A&D maintained at 37 degrees Celsius body temperature, kept warm during the entire processing, transport, and clotting time.
Why?
Because if that serum is allowed to cool down, even for a short period, you risk having those abnormal cryoglobulin proteins precipitate out right there in the test tube. That leads to a falsely low or even falsely negative result. Missing a diagnosis of cryoglobulinemia because the sample wasn't handled correctly. That's a major diagnostic error, given how serious HVS can be.
Absolutely critical handling instruction. And given the high association of mixed cryo with infections, what else needs to be ordered right away?
You must test for hepatitis C and B serologies immediately. HCV in particular is the most common underlying cause of mixed cryoglobulinemia, type 2 and type 3. Treating that underlying infection is the key to long-term control. And finally, if you're considering erythrocytosis as the cause, you need iron studies.
This is crucial because, as we'll discuss next in management, the patient's iron status profoundly influences your treatment choices, particularly around phlebotomy.
Perfect segue. Let's turn our attention to acute management. The interventions needed right now to stabilize the patient once you suspect or confirm HVS. And you've stressed the approach is entirely etiology-specific, right? Reflecting those two different mechanisms, protein versus cells.
Exactly. So for symptomatic HVS that's caused by elevated plasma proteins, whether it's IgM from Waldenstrom or high IgA from myeloma or type 1 cryoglobulinemia therapeutic plasma exchange or plasmapheresis, is the undisputed first-line treatment.
And why is plasma exchange so effective and so rapid in these protein-driven situations?
Well, plasma exchange works by physically removing the large viscosity-driving proteins directly from the plasma component of the blood. It's mechanical removal. These proteins, especially the huge IgM pentamers, reside mostly within the intravascular space. So by taking out the patient's plasma and replacing it with a substitute fluid like albumin or maybe fresh frozen plasma, we achieve an immediate, often dramatic reduction in the serum viscosity. And that translates to near immediate symptom relief, often within just hours. This is truly the acute, life-saving maneuver for protein-driven HVS.
So getting hematology or maybe critical care involved early to arrange plasmapheresis is key.
Absolutely crucial. That rapid decrease in viscosity is often the only thing standing between that patient and irreversible damage, like a stroke or permanent blindness.
And plasmapheresis is generally pretty efficient, right? A single exchange can remove a significant chunk of the bad protein.
Yes, typically a single plasma volume exchange can remove around 60% of the offending paraprotein. The clinical benefits are often obvious very quickly, sometimes even reversing acute neurological decline while the procedure is still happening.
That speed is critical. Okay, but what about the other scenario, the cellular-driven hyperviscosity, specifically that hyperleukocytosis from leukemia? Plasmapheresis won't help there.
Correct. For hyperleukocytosis, which we see primarily in acute leukemias, especially AML, the treatment is leukapheresis. This is a fundamentally different apheresis procedure.
How does leukapheresis work?
Leukapheresis focuses specifically on rapidly decreasing the cellular burden. It physically removes the excess white blood cells from the circulation without really affecting the plasma proteins much at all. It's indicated when there's clinical evidence of leukostasis, those symptoms related to pulmonary or CNS microvascular occlusion, or often we do it prophylactically if the blast count is extremely high, say over 100,000, to prevent leukostasis from developing. The immediate goal here is to prevent acute end organ damage from cell sludging, not primarily to reduce plasma thickness itself.
So it's really a numbers game, reducing the sheer volume of those problematic cells. Okay, now let's tackle that tricky situation. The patient presenting with secondary erythrocytosis, maybe from cyanotic heart disease or living at high altitude. Their treatment strategy is markedly different, almost counterintuitive, you said.
Yes, this is where we really need to exercise extreme caution and clinical judgment. The first-line therapy here is supportive care, primarily focusing on hydration, oral or IV fluids. The reason that aggressive phlebotomy, which might seem logical to thin the blood, is generally discouraged in secondary erythrocytosis is because these patients are chronically hypoxic. They actually rely on that higher hematocrit to maximize their oxygen delivery to tissues.
Right, so if we just phlebotomize them aggressively, we might temporarily relieve the viscosity, but we'd actually decrease their oxygen carrying capacity, potentially making their underlying tissue hypoxia even worse.
Exactly right, it can backfire. So phlebotomy is really reserved only for severe refractory symptoms that are clearly attributable to the hyperviscosity itself, and not just the underlying hypoxia. Furthermore, doing routine or overly aggressive phlebotomy is dangerous because it can easily induce iron deficiency. And studies suggest that when these patients become iron deficient, their red cells actually become smaller, microcytic, but also more rigid. Ironically, this can increase whole blood viscosity and worsen symptoms, even though the hematocrit number might be a bit lower.
Wow, okay. So the goal isn't to normalize the hematocrit, it's just to treat the severe symptoms of viscosity if they arise. And we should only give iron supplements if we've definitively confirmed iron deficiency.
That is absolutely correct. In fact, if phlebotomy is deemed necessary, it should probably be done cautiously, perhaps in conjunction with volume replacement, and only aiming to reduce the hematocrit to a level that relieves symptoms, maybe getting it below 65%, for example, rather than shooting for a normal range like 45%. We are aiming for symptomatic relief while trying to minimize the harm from sudden shifts in blood volume or oxygen carrying capacity.
Okay, that's a critical distinction in management. Now, beyond these immediate interventions like apheresis or hydration, let's talk about monitoring and the crucial long-term strategy needed to prevent this from just coming right back.
Right. Monitoring has to be frequent, and it needs to be focused primarily on clinical assessment, especially watching for any changes in neurological status or vision. Serial fundoscopic exams remain indispensable here. Yes, we do rely on serial lab tracking following the quantitative immunoglobulins or the cell counts, but let me just stress this one more time. Clinical symptoms always guide the urgency of intervention. If the patient's symptoms worsen, you repeat the apheresis, regardless of what the most recent serum viscosity number says.
Because the apheresis is really just buying time, isn't it? It's a temporary fix, a few days, maybe a week or two at best. We have to address the underlying factory producing the protein or cells.
Absolutely, you hit the nail on the head. The long-term prevention strategy demands early initiation of disease-directed therapy. That means starting appropriate anti-myeloma agents, or maybe Bruton's tyrosine kinase inhibitors for Waldenstrom, or induction chemotherapy for acute leukemia. This definitive therapy has to get the underlying disorder under control to prevent a rapid rebound hyperviscosity after the temporary effect of apheresis wears off. And for mixed cryoglobulinemia, that disease-directed therapy is often antiviral therapy for hepatitis C. Apheresis is the bridge, but the definitive treatment for the underlying disease is the destination.
It's interesting how these principles, developed largely in hematology and oncology, are now finding applications in other areas, even infectious diseases.
Yes, the basic rheological concepts are transferable to any state where blood gets too thick. There's definitely emerging data now, mostly from case series so far, looking at the use of therapeutic plasma exchange in COVID-19 associated hyperviscosity, particularly in patients who are critically ill with high levels of inflammatory markers and severe respiratory failure. The rationale is similar, trying to remove high levels of inflammatory proteins, fibrinogen, perhaps immune complexes that might be contributing to viscosity and microvascular issues. Some case reports have shown rapid correction of viscosity and clinical improvement. Still early days, but conceptually it makes sense.
Fascinating. Finally, let's consider the prognosis. HVS sounds like it's not a benign complication at all. It often signals pretty aggressive or advanced underlying disease, doesn't it?
It definitely carries significant risks. HVS is associated with increased early mortality, particularly in older adults, and especially in those who present with severe CNS involvement or major bleeding episodes. The complication rate is substantial.
And the source material highlighted some particularly concerning data for multiple myeloma patients. HVS seems to be a really poor prognostic sign in that specific group.
Yes, it's a critical marker of badness in myeloma. When HVS occurs in newly diagnosed multiple myeloma, it's associated with significantly poorer overall survival. The data suggests a median survival of only about 3.6 years for those patients, compared to maybe 7.7 years for similar myeloma patients who don't present with HVS.
Wow, that's a huge difference.
It is. The risk of dying early, especially in patients over 65, is markedly increased. It likely reflects a very high burden of disease at diagnosis. Furthermore, any complications that persist after the acute HVS event is treated things like irreversible vision loss from retinal damage, a permanent stroke deficit, chronic heart failure from the strain. Those significantly worsen the patient's long-term functional status and overall prognosis. So while prompt apheresis absolutely improves the acute outcome and prevents immediate catastrophe, the patient's overall survival really hinges entirely on getting rapid and successful long-term control of the underlying hematologic disease.
Okay, let's try to summarize the key clinical takeaways then for managing acute hyperviscosity syndrome. First, vigilance regarding that classic triad bleeding, visual changes, neurological deficits, that's paramount. It's your fastest diagnostic clue.
And that vigilance needs to translate immediately into action. Urgent initiation of apheresis plasma exchange for protein-driven HVS or leukapheresis for the cellular-driven type must be based on the clinical symptoms. Don't delay waiting for viscosity lab results to come back. And remember that important exception. Secondary erythrocytosis requires caution, with aggressive hydration being the first step, not necessarily phlebotomy.
And we really need to treat the physical exam like a lab test itself. Specifically, the fundoscopic exam is a critical diagnostic tool. We should use it frequently because those retinal changes can be an early defining feature, giving you objective confirmation sometimes hours before the labs return.
Absolutely. Your ophthalmoscope is the fastest viscometer you possess in this situation. And also, don't forget the differential diagnosis, especially if the presentation looks more vasculitic. Get that hepatitis E serology ordered immediately if you're considering mixed cryoglobulinemia.
We also discussed how certain very high immunoglobulin levels specifically, that IgM level over 60 grams per liters in Waldenstrom, are strongly predictive of symptomatic HVS and might even warrant thinking about preemptive intervention. And this raises a really interesting question about risk stratification, doesn't it? Particularly given the terrible prognosis you mentioned for HVS in newly diagnosed multiple myeloma.
It does. Given that stark difference in survival for myeloma patients who present with HVS versus those who don't, the challenging question becomes, are there other specific clinical or laboratory thresholds we should be looking for? Maybe something based on how fast the monoclonal protein is rising, or maybe the severity of rouleaux formation on the initial smear. Should markers like these trigger earlier, perhaps preemptive apheresis or maybe more intensive initial induction therapy, in those high-risk myeloma patients who haven't yet developed full-blown HVS symptoms? Finding that reliable trigger beyond just waiting for symptoms or a high viscosity number is a really tough risk stratification problem that we still grapple with in hematology.
That's a vital point for critical thinking and definitely an area for future research in this very high-stakes part of hospital medicine. Thank you so much for this incredibly informative deep dive into the acute diagnosis and management of hyperviscosity syndrome.
It's been a really important discussion. Thank you.
This has been the Hospital Medicine Unplugged podcast.